So today, I really shouldn't criticize vancomycin because it ensures I have employment for the rest of my life because it's so overused. But we're going to talk a lot, mostly focusing on vancomycin when it's appropriate, screening for MRSA, and really trying to narrow down your treatment for patients with skin and soft tissue infections.
Charlie, I'll cover these. So these are just a couple disclaimers letting you know that we do record these sessions and make them available for maybe anybody who wasn't here to join us, or even those of you who are joining us and maybe just want to refer back at a later date. If you have any concerns about being on that video, just let us know, send us something through the chat box, and we can edit you out of any portions that you're present in. Reminder here, if you do present any specific patient cases for us, please just don't disclose any protected health information, and our disclosure policy, just so we can provide CME and CEU credit for the session here today, letting you know that no presenters have any conflicts of interest.
So I'm going to start off by just reviewing what vancomycin is, what is it, how does it work, and we'll be applying some of that information like when we do screening and stuff like that. So vancomycin is, in most hospitals, is the #1 or #2 used antibiotic. And it has a lot of potential toxicities, but also a very effective antibiotic. So I'm going to use it particularly appropriately. And so vancomycin works against what we call gram-positive bacteria. And my next slide will show you what that's about. But basically, it covers gram-positive bugs like pneumococcus, strep, enterococcus. But 95% of the time, we're using vancomycin for what we call methicillin-resistant Staph Aureus. So we have alternatives. Like for strep pneumo, we don't need vanco for that. But for MRSA, it's particularly carved out a role for the treatment of MRSA. And so we're really going to focus in on MRSA and vancomycin and how it works. It doesn't have any activity against what we call gram-negative bugs or anaerobes. And I'll show you why on the next slide. So if you remember from microbiology, we have two types of bacteria. One are called gram-positive. The gram-positives are the ones on top with a big, thick cell wall. So when you stain it, that cell wall holds onto the purple. So under the microscope, it looks purplish, and we call that gram-positive. Gram-negatives, which are on the bottom, have the cell wall, it's sort of like sandwiched in between a membrane. So antibiotic such as vancomycin, which affects gram-positive bacteria, can get right up to the cell wall in the gram-positive bacteria and be effective, but it's such a big molecule that it cannot get through that cell membrane, so it has no activity against gram-negative organisms. And so gram-positive gram-positive have this big cell wall on the outside, and it's made up of these long chains of sugar molecules and proteins called peptidoglycans. And the cell wall is sort of like it's like the outside of a castle. It keeps the inside of the bacteria safe and prevents it from being killed. The final step of making this outside cell wall is an enzyme called penicillin binding protein 2A. So this enzyme completes the construction of the cell wall. And it's called a penicillin binding protein because beta-lactam antibiotics like penicillin, cephalosporins, carbapenems, they all bind to it. And by inactivating this enzyme, the peptidoglycan cell wall cannot be completed, it degenerates, and the bacteria kills. So beta-lactam antibiotics work binding to this penicillin binding protein and blocking the ability of the gram-positive organisms to replicate. And so MRSA, so methicillin, we call methicillin just like nafcillin, also works by binding to this penicillin binding protein. But what happens over time is that this enzyme, penicillin binding protein 2A, can mutate itself. And it can mutate itself so that no longer beta-lactam antibiotics like nafcillin, methicillin, cefazolin can bind to it. If the bacteria can still use this mutated enzyme, it has an advantage now because now drugs like nafcillin, cefazolin don't work at all and it can replicate. What vancomycin does, vancomycin also binds to this penicillin binding protein 2A, but it's not affected by this mutation. So vancomycin works against gram-positive bacteria, and it works specifically in Staph aureus, which has a mutated enzyme where penicillin, cefazolin don't bind to it, but it is able to knock off that final step. And so it has a particular role, right, as we talked about, 95% of the time, it's used for this methicillin-resistant bacteria, which means it has an altered penicillin binding protein, but vancomycin still works. So kill off this resistant bacteria. Okay, next slide. So that's how it's basically works against MRSA where other antibiotics do not. So let's start off with the case and see what role what vancomycin has. So this is a typical patient you may see in the emergency room. 67-year-old overweight diabetic patient comes in with cellulitis and sepsis. Here's a peripheral vascular disease, neuropathy, ulcers on his feet. He comes in with confusion, fever, and a rapidly progressive rash moving up his leg. He has a fever, heart rate is up, and a blood pressure of 100/68. So here's a man with cellulitis and sepsis. The emergency room doctor, next slide. The emergency room doctor notices this rapidly progressive rash going up the man's leg. And he's concerned. He says, this guy's very sick and I want to cover everything. And so like a typical ER doctor and other physicians, he puts him on vancomycin and Zosyn to cover all possible causes of this leg infection. And we'll come back to this patient a little bit later and see what you think about it. Next slide. So cellulitis, what we call non-purulent cellulitis, and all these other types of skin infections are sort of lumped under the rubric of skin and soft tissue infections. But these are very different, distinct clinical syndromes, but they're all, in studies, they're oftentimes just referred to as skin and soft tissue infections. So they can be from cellulitis with no drainage of pus. It can be a cutaneous abscess. It can be a diabetic foot infection. It can be a surgical site infection. And it could be a necrotizing soft tissue infection. So for most of the studies that we read about, they're all thrown together into one pile and grouped together for treatment. And so this commonly results in the same antibiotic approach used to treat all of them. The same approach may go for a diabetic foot infection as for cellulitis or a cutaneous abscess. And this results in, as we'll see, in the gross overprescribing of antibiotics. Next slide. These are some examples of the skin and soft tissue infections. On the left side, we can see what we call non-purulent cellulitis, a rash, red rash going up the leg. There's no pus. And so we call it non-purulent cellulitis. On the right, we can see sort of a typical severe diabetic foot infection with gangrene, swelling, and drainage. Next. A cutaneous abscess. There's a drain in this one, and there's a localized purulence coming out. And then we have a surgical site infection. Maybe a week after the patient undergoes surgery, he comes with a red, tender surgical site. So these are all thrown in together as skin and soft tissue infections, but you can see they have very different clinical presentations. And so the antibiotic regimen, which may be appropriate for a diabetic foot infection, may be overkill for a non-purulent cellulitis. Non-purulent cellulitis, as I showed you in that prior picture, almost always is caused by strep and not staph. But despite this fact, studies show continued heavy dependence on MRSA therapy for all soft tissue infections. There was one multi-center study looking at, again, non-purulent cellulitis, reported that vancomycin was the most commonly prescribed antibiotic, 60% of the time, oftentimes combined with Unicin or Zosyn, clindamycin, and Cefazolin is actually the last choice for patients presenting with non-purulent cellulitis. Another study looked at non-purulent cellulitis, found 85% of these patients received MRSA therapy, mostly vancomycin. So if we bring out the non-purulent cellulitis and look at these people specifically, or oftentimes being treated for MRSA, how much do we really need to use vancomycin in these studies? And so there's actually been 2 randomized studies looking at the use of empiric MRSA, anti-MRSA therapies such as vancomycin in the treatment. One was a study in 2010, it was a prospective study where they gave Cefazolin. Cefazolin is great against strep, as well as activity against regular Staph Aureus in hospitalized patients with non-purulent cellulitis. They did blood tests on these patients. 75% of them had evidence for strep serologically, and 96% of these patients responded to Cefazolin. So we have studies, one study suggesting that Cefazolin without MRSA coverage, 96% of the patients did well. There was also a study that was reported recently, where they had emergency room doctors. They said, patients that come in with non-purulent cellulitis, let's see whether or not we really need empiric treatment for MRSA. So half the patients, since these were outpatients, were given Keflex. Keflex is similar to Cefazolin, covers strep, staph, but doesn't cover MRSA. Half were given Keflex. The other half were randomly given Keflex plus Bactrim. Bactrim covers about 98% of MRSA. So they're wanting to know if, even though it looks like non-purulent cellulitis, does a patient benefit from anti-MRSA coverage? And as we'd expect, there was no difference in outcome. So again, suggesting that if you don't see purulence in the cellulitis case, do we really need to add vancomycin? And the studies would suggest that we don't, because almost always it's a strep infection. So non-purulent cellulitis is really sort of a cutout from that whole skin and soft tissue infections, but we'll talk about those now. Next. So what's the big deal about using a little vancomycin? And really there's a lot of issues. There's no free lunch with using vancomycin. It is a toxic drug with many potential side effects. So let's talk about some of these side effects that you should be aware of. So we got to get away from using this term red man syndrome. First of all, it's derogatory to Native Americans, but also importantly, in terms of the clinical diagnosis, we've heard of red man syndrome where people get vancomycin given too quickly. It causes histamine release. There's occasions their skin turns red. And if you just slow down the infusion and give them antihistamines, it goes away. And so that sounds, first of all, two things about this. First, besides being derogatory, red man syndrome doesn't apply to people who have dark complexion. There was a study in 2012 where they studied the diagnosis of, quote, red man syndrome in whites, and they compared it to blacks, and they found it was 12 times more likely diagnosed in whites and blacks. And the authors were suggesting that somehow race-based difference in how the mast cell responds. But actually what's going on was that they were looking for the classic red man in whites, but not realizing that in people of darker complexion, they may not actually have a red skin. They would just have other presentations. And so it should be called, the new recommendation we call it the vancomycin infusion reaction. And when I was writing these slides up, actually the New England Journal, this article has an article this week about it. And they gave some pictures. Next slide. So these are, you can see lighter skinned people getting the classic rash, but in darker skinned people may not, they may have a reaction to the vancomycin, but you may not recognize it because their skin is not turning red. And so it is not just red man syndrome, but it should be called the vancomycin infusion reaction. And that is a much better way to describe this reaction. Secondly, you can get the histamine reaction, but you can also get a long-term rash, a typical drug rash with vancomycin. This is not urticarial, it's not itching, and it doesn't resolve quickly, unlike the vancomycin infusion reaction, which responds to histamines, but gives you a drug rash, like any other drug rash. And these patients should not be re-challenged. So the infusion reaction, you can re-challenge. This rash, you should not. And also, nephrotoxicity is a major problem with vancomycin. And there's been studies suggesting that the trough level, the higher your trough level is, the more likely you're going to have a significant reduction in GFR in patients. And so this study, patients with GFR, a trough level greater than 20, 66% of them had a significant drop in renal function. Next slide. And also, not only does vancomycin itself cause renal insufficiency, there seems to be some kind of synergy between vancomycin and Zosyn. So this was a study, retrospective study, where they tried to equalize risk factors, age, sex, illness, trough concentrations, and they compared vancomycin plus Zosyn in terms of renal toxicity versus cefepime and vancomycin. So both cefepime and Zosyn have similar activities against gram-negative organisms, but when you add vanco, they had almost twice the high an incidence of renal toxicity in patients who were treated with both Vanco and Zosyn versus Vanco and cefepime. So not only is Vanco itself toxic, potentially to the kidneys, but there seems to be a synergistic effect when it's combined with Zosyn, and we typically see Vanco and Zosyn put together. And so it really reinforces the need for judicious use of combination empirical antimicrobial therapy. Next. And what is the consequences of vancomycin toxicity? First of all, increased length of stay in patients with acute kidney injury, in patients admitted with MRSA bacteremia compared to those without acute kidney injury, longer times in the ICU, increased risk of needing hemodialysis. And unfortunately, we've seen patients who have been discharged to nursing homes to complete vancomycin therapy with not a careful attention being made to their trough levels and developing a complete renal failure. So it's not a benign drug at all. Next slide. So how can we get away from using vancomycin? And so one way that's really got a lot of attention, has been very helpful for us at doing antibiotic stewardship, is to do nasal screening for MRSA, because there's a great correlation between a positive MRSA screen from the nose and the presence of MRSA in the culture. And so we have two ways of doing it. On the left, you do a nasal swab, and you can see on that agar, if the MRSA grows, it turns that bluish color. That takes about 1 to 2 days, but is a relatively inexpensive test. The other test is the Cepheid or Gene Expert test. This is the same machine that looks for the RNA for COVID, but what it does, it finds the gene that makes that altered penicillin binding protein. We talked about earlier about the gene, the penicillin binding protein 2A, which mutates itself, which makes it resistant to killing by the penicillins, but makes it active against vancomycin. So this test is a very quick PCR test, and it looks for the gene called the MECA gene. If it's present, it tells us that there's an altered penicillin binding protein being made by that staph, and we have to consider the possibility of a MRSA infection. So the one on the left, cheap, not as completely sensitive, about 80% sensitive about picking up MRSA, but takes 1 to 2 days. The MRSA screen on the right, the PCR test is very quick, within about an hour or two of it being run. So it gives you a little bit, costs more, but it gives you a quicker return on your answer. And so why screening for MRSA nasal colonization in skin and soft tissues may be useful? There's been multiple studies which look at purulent skin infections. So not looking at patients who have pus, whether it's a cutaneous abscess, diabetic foot infection. And what they have demonstrated is a positive predictive value, which means that if it's positive, it tells you MRSA is present, but it doesn't tell you that it's actually the cause of infection. So you could have a positive predictive value about 50%. So you could have MRSA in your nose, but doesn't mean that MRSA is actually present in infection. It may just be colonizing. So that usually about a 50 to 65% range. So, but what's probably more helpful is a negative MRSA screen will have a negative predictive value, which means a negative test means that MRSA is not the cause of the infection of between 80 to 98% of the time. So a negative MRSA screen can be very helpful, hopefully comfortably stopping the MRSA activity. A positive one just tells you there's MRSA present, but may not be the cause of infection. So an approach to these patients with mixed infections, with diabetic foot infections, if a patient does not have a history of prior documented MRSA and has a negative MRSA nasal screen, it may be appropriate to discontinue anti-MRSA therapy, particularly in diabetics, may help prevent unnecessary renal toxicity. Next slide. So let's go back to this patient. How would you manage this patient? Comes in the ER, he's septic, and he's a little bit, he has fever, tachycardia, and he's got this leg on the right. That what would you do for this patient? Would you continue vancomycin, or would you consider an alternative therapy? Anybody wants to speak up, would be great.
Would consider alternative therapy.
Dr. Krasner, consider alternative therapy is what I heard.
Yeah, so we don't see any pus there. We see diffuse redness, And so we think we would call this a non-purulent cellulitis, right? So as we've talked about, these patients do not have staph or MRSA. So I would, in this situation, instead of doing vancomycin, I think a drug like cefazolin or unicin or penicillin would be a much more appropriate and safer treatment for this patient. Again, just because the patient is sick, if you're going to examine the patient, you don't see any pus, it's diffuse redness typical of cellulitis, I would avoid using vancomycin and Zosyn. The other thing about Zosyn covers anaerobe pseudomonas. This is obviously not a mixed infection. This is just a superficial strep cellulitis. So I would encourage people not to do that. But sometimes they get admitted by the ER and then they're doing a little better the next day and the hospitalist is concerned. I'm not really sure. And they'll keep on the vancomycin for days, even though it's a typical strep infection. Next slide. So how would you manage these infections? This patient walks in complaining of a rash on their face on the left. It's a skin and soft tissue infection. Do we see any purulence? No. Would you give them Vancomycin, or what would you consider for this patient?
Ampicillin or penicillin.
Beautiful. Yes. So this is what's the diagnosis of this infection?
Erysipelas.
Perfect. So excellent. So it's like this. We call it erysipelas because you can see the edges of the infection. So that's a very superficial epidermal infection. So this is erysipelas. And I've seen patients like this come in and they say, "Oh my God, cavernous sinus thrombosis, give them vancomycin." So the patient would be sitting there smiling, but he'd have this rash. So there's no reason. Ampicillin, penicillin, cefazolin would all be perfect choices. So contrasted on the right side, what would you be concerned about?
MRSA.
Right, so staph infection. So that would be, I mean, obviously it looks like abscesses are developing there. So if the patient has a history of MRSA, I think vancomycin would be very good. But let's say you're not able to culture it out because it hasn't come to a head. So doing an MRSA screen might be very helpful in this patient. If he has no history of MRSA, he has these lesions, the MRSA screen is negative. You know, the positive predictive value, a positive predictive of a negative test is that almost certainly this is not an MRSA infection. So you may want to just switch him to a drug like cefazolin.
Dr. Warko, do you have a question?
I do, Dr. Krasner. I just wanted to ask, with that first gentleman with what appeared to be the strep cellulitis, if he had gotten a MRSA screen, you know, like the universal screening that the VA does, and it was positive, would that change your management at all with your antibiotic selection? Are you sure enough that that looks like strep that it's okay despite a positive MRSA nasal swab to continue?
Again, we just talked about that. An MRSA positive one still has a very poor predictive value, about 50%. So what I would do, I would examine his leg. I'd feel all over the skin. Is there any purulence coming out? Is there any localized infection? But a MRSA infection does not present with diffuse cellulitis or a staph infection. It produces with localized abscess formation. So if you go, Troy, go back to that picture again. Yeah, so you can see there's no abscess there. It's just diffuse redness going up his leg. That's not the way staph would present. Staph would present with localized, you know, abscess formation or something else like that. But it's just going up rapidly. Staph doesn't work like that. Strep is the one that always works like that. And I would feel very comfortable. I mean, I've seen thousands of this. So to say that I am sure that this is a non-purulent cellulitis, and I would just do cefazolin or ampicillin or penicillin.
Okay, great. Thank you.
So let's look at these two. How would you manage these? For anybody who listened to the lecture last month, what about the left side?
Staph dermatitis.
Beautiful. All right, goes ahead of the class. So we talked a lot about staph dermatitis. Cellulitis, does not present with one side leg. You don't see this kind of excoriation, this kind of desquamation of the skin, and it's been there for a long time. But we see a tremendous amount of stasis dermatitis being treated with broad spectrum antibiotics. They said they failed Keflex, so they go Vancomycin, but that was last week's test. So this is, I would manage that with steroid cream and wraps, and you would improve. How about the foot on the right? The diabetic patient. Well, you see, it looks like a localized swelling there. Well, very good. Pseudomonas aeruginosa, a diabetic patient, you can see where that shiny light is. It looks like there could be an abscess there. There's necrosis going on. So I think that would be a fine situation. It's a soft tissue infection. It's not just a superficial skin infection. And they could have purulence, they could have an abscess. So actually that would be a situation where Vanco and Zosyn would be very helpful initially while you're evaluating the patient, see if there's anything you can drain. But do a MRSA screen on this patient. If he's MRSA negative previously, your MRSA screen is negative, I think I'd feel real comfortable just going with, for example, Zosyn without the Vancomycin. Next. So how can we reduce Vancomycin use? Really don't use Vancomycin for non-purulent cellulitis, almost certainly strep. Try Cefazolin, Untitled, or simply ampicillin. Do nasal MRSA screening for purulent soft tissue infections. A negative screen can allow more rapid discontinuation of MRSA coverage. Not only you need to continue, if somebody's not bacteremic, you can certainly, even while you're waiting for the test results, switch to, for example, oral linezolide. Linezolide is about $5 a tablet these days. It has great penetration. It covers staph, strep, MRSA, or doxycycline, which covers about 90% of MRSA, and Bactrim, which covers about 98%. So, you know, you got a diabetic patient with an infection, you're still evaluating. The Vancomycin, you know, in 2 days they could be in renal failure. So you may want to consider, if they're not bacteremic, switching to one of these oral options for these patients. It's a very safe alternative and very effective. And remember, again, the echo talk on pseudocellulitis, 40% of cellulitis cases are not infectious, particularly if no fever and bilateral. And try not to use empiric Vancomycin, too high risk for neurotoxicity. I think I would reserve this for a sick diabetic patient with out of control diabetes, or somebody with a necrotizing infection would be more appropriate. But most of the time, it's, you know, it's just either a localized staph or a localized strep infection. You can be pretty comfortable with Untitled plus or minus Vanco or an oral agent. So, best journal title ever. This was an article came out called Overtreatment of Non-Purulent Cellulitis, Things We Do for No Reason, was the title. And again, really the overuse of particularly Vancomycin in non-purulent cellulitis is a major problem. And it does have a role, but try to get, if you can, look at the patient, see if they've had MRSA in their nose, see if they had prior MRSA, and try to get them off the Vancomycin as soon as you can. Jessica, or Kia, anything you'd like to add?
That was an excellent presentation.
I just, you know, I think, you know, we're fortunate to have the antibiotic stewardship teams because we have, you know, enough people, but in smaller hospitals, you know, a lot of doctors are, you know, they don't have the guidance from us. And sometimes they feel, you know, they feel a Vancomycin and I can walk away from the patient because it's going to be fine, but it's not a benign treatment. And even though, you know, we do antibiotic stewardship, Vancomycin is extremely cheap. You know, we're not doing it for money saving. We're doing it to protect the patient from potential toxicities, the need for IV therapy. And if we can get them on oral treatment as soon as possible, I think if they're not bacteremic, it can be very helpful.
Dr. Krasner had kind of a little case presentation shared from Nick earlier in the session. So he says the combo Bactrim and Keflex is a rather inexpensive outpatient treatment therapy for a great outcome. However, I had a patient case with sub-Q abscess on this regimen, and the Bactrim flared his gout by his 8th day. Would you then consider an alternative for Bactrim like doxycycline for atypical organism coverage?
I think Doxy has atypical coverage, but in that situation, it's a really good drug for MRSA infections. So, if I see someone who has, just a cellulitis, I think Keflex is fine or Augmentin is fine. But if I'm not sure that there could be a staph component, I think like Augmentin or Keflex and Bactrim is an excellent combination, or doxycycline. Sometimes, we have people on lisinopril who have kidney issues, and you get nervous about using Bactrim because of the hyperkalemia. Doxy has worked extremely well, particularly in the outpatient setting where we don't see almost any resistance to it, and it's cheap and it's well tolerated. But again, as I said, if you're convinced it's just a non-purulent cellulitis, that study from the ER suggests adding Bactrim to it didn't add anything. But again, if you're concerned that there may be an abscess, doxycycline is excellent. Doxy and Keflex is a good combination.
All right, Nick said, I think you answered that a little bit earlier in the session. Nick, did you have another question? Do you want to unmute and ask that? Nick, we have audio for you if you could unmute yourself, please. All right, I'll read it out here. He just asked, what do you, all right, he's saying no microphone. What do you think about Proteus vulgaris skin infection?
In what situation did you see it? Most of those enterics and anaerobes will cause an abscess. And so you would usually see that in like a setting like a diabetic foot infection or something else like that, or a postoperative wound infection. It by itself would not probably cause a cellulitis.
He says
groin infection. Yeah. So that's probably like a mixed enteric and anaerobic infection. And groin infections could be two things. One, they could be just a superficial, like a staph infection with a boil, or it could be like a stool type thing where there may be a fistula or some other appendix related. And that's where, you have to decide, is it just a draining, pustule, or is it from deep inside, like, as I said, like fistula stuff. So drugs like Unicin would be very good in that situation, to use, or Rocephin and Flagyl.
He said it was in the skin folds.
That may just be poor hygiene.
All right, other questions from the group for us here today? Feel free to unmute yourselves or write in through the chat box, please. Nick says he's got one more.
Okay.
Go ahead, I think he's writing that in.
So, just look at the leg, don't, skin and soft tissue infections, don't just throw them all together. If it's a non-purulent cellulitis, it's almost always strep. And use the screening to really help direct you in direction, and try to get them off the vancomycin if you can.
Okay, so Nick's asking about co-infection with an antiviral and MRSA.
So, people sometimes will get like chicken pox or shingles, and those are very common. You give acyclovir or valcyclovir, and you give a Bactrim or a doxycycline for the secondary infection. That's very common. And that's, kids used to get chicken pox and they get a secondary strep infection and get toxic shock and stuff like that. So open herpes type lesions and varicella lesions oftentimes do get infected.